Today, in this section, we are going to be considering contraceptive implants. I'm Dr. Stephen Omitinde. I'm the Senior Registrar in the Department of Obstetric Gynecology of Afemi Awolowo University Teaching Hospital, Ile-Ife. After this discussion, you are supposed to know what contraceptive implants are, the different types that are available, the mechanism of action, the health benefits, the indications, and how you can insert and remove them. Contraceptive implants are progestin-based, long-acting, reversible method of contraception. And these are small, flexible rods that are just placed under the upper arm. It is highly efficient and makes its use appealing to teenagers who may actually find adherence to oral contraception regimen difficult. Most of these teenagers also, they use less effective method of contraception like withdrawal. This put them at risk of unwanted pregnancy and are prompted to request for unsafe abortions. It's also useful in adult women who desires a long-term method of contraception or has completed their family size. These contraceptive implants, they have similar physical effects, pharmacological profile, and they can be considered one after the other. I will talk about a bit of history about contraceptive implants now. The Population Council commenced research into implants in early 1960s, and they realized that cellulosic rubber capsules released continuous level of steroid hormones, and this research gave back to the Norplant method of contraception. This is a levonorgestrel containing 6-rod capsule. It was developed in 1983 in Finland. However, Norplant suffered a lot of negative media coverage, and its production was discontinued completely worldwide in 2008. This is because some women complained of some abnormal complaints about implants, and these complaints actually disappeared when the implants were removed. And so research was continued about contraceptive implants, and this further research gave back to Jadel contraception. This was also manufactured in Finland, and it has been in existence since 2003. Jadel is a better design when compared to Norplant in terms of insertion and removal. It is easier to insert and easier to remove when compared to Norplant, and this makes its acceptance increase. Sino implant, it is manufactured in China. It is cheaper when compared to Jadel. It's also a 2-rod levonorgestrel implant, and is actually a replication of Jadel, so they can be considered for each other. In 2006, further research by the FDA gave back to the Implanon contraceptive implants. It's a single-rod heteronorgestrel implant. It is a great improvement on the Jadel because it makes insertion of the implants easier when compared to Jadel or Nexplanon, and many women accepted it better when compared to Jadel. Nexplanon, however, is also an improvement on Implanon. It's actually about equivalent of it. It's actually radio opaque, which makes it visible when an X-ray is done in order to identify and locate it after it has been inserted. The insertion is also simplified because somebody can actually insert it using one hand only without the help of the other hand. And the design has been improved such that it is implanted directly subdermally. And this reduces the chance of not being able to palpate it after insertion if it inadvertently inserted into the subcutaneous tissue. I'm talking about the pharmacology of implants now. Now we are going to focus our discussion on Nexplanon, which is the most common implant that is available presently. And Nexplanon is a single implant. It is inserted in the upper arm of the non-dominant arm. It's a 4 millimeter in length and it's 40 millimeter in length and 2 millimeter in diameter rod, and it consists a non-biodegradable rod, which is 40% of the plastic ethinyl vinyl acetate, and 60% of it contains the etonogestrel, which is actually a 3-keto derivative of desogestrel. Each rod contains 68 milligrams of etonogestrel, and it achieves a serum concentration of 266 picogram within the first 24 hours of insertion. And this is very significant because it's only 90 picogram of etonogestrel that is actually needed to achieve contraceptive effects. And this has been shown in studies that this level of contraception it inhibits ovulation in 97% of women that are using it. And the progestin release rate is usually high in the immediate insertion period. And in the first year of use, it's about 60 to 70 picogram per day that is released into the circulation. This decreased gradually to about 35 to 45 microgram per day at the end of the first year of use. The release rate reduces gradually by the end of the second year of use to about 40 microgram per day, and by the end of the third year of use, it's actually between 25 and 30 microgram per day. Etonogestrel is about 32% bound to sex hormone binding globulin and 66% bound to albumin. This makes it almost 100% available for the first 2 years of its use. And however, one needs to realize that enzyme-inducing drugs like efavirenz, carbamazepine, and phenytoin sodium, they reduce the serum concentration of etonogestrel. So this might a little bit affect its serum level, but there are no studies that actually shows that it reduces the contraceptive efficacy. However, in women using these drugs and concomitantly on Nexplanon, they might have to use a follow-up, like a backup contraception, to avoid conception. The half-life of etonogestrel is about 25 hours, and as such, it makes it undetectable within 1 week of removal. So what does it tell us? This tells us that when the implant is removed, there is rapid return to ovulation and conception. And actually, studies have shown that within 3 to 6 weeks of discontinuation of this method on contraception, ovulation returns in about 94% of women. Nexplanon is impregnated with barium sulfate salt, and this makes it opaque, radio opaque, unlike Implanon, which is not detectable by X-ray, such that when the implant is inadvertently implanted into the subcutaneous tissue and it could not be palpated during physical examination, one can do an X-ray and be able to identify and locate the implants. I would be talking about the mechanism of action of Nexplanon. When Nexplanon is implanted into the arm where it is located, etonogestrel diffuses from the implants to the surrounding tissues, where it is absorbed by the microcirculation, and from there it is distributed systemically. The release rate is determined by the total surface area of this implant and the density of the containing plastic. And the two mechanisms of action has actually been described. And the first one is inhibition of ovulation. And it has been observed, that implants containing progestin, when it is released at a consistent level, it inhibits gonadotropin release in the anterior pituitary, and at this reduces maturation of follicles and subsequent ovulation. So women that are on implants, they are unlikely to ovulate, especially in the first 2 years of ovulation, of use. However, studies have shown that in the third year, towards the end of the third year of use, the implants might not consistently stop ovulation. This is where the second important mechanism of action comes in. It alters the cervical mucous plug. This it does because progestins, because of their anti-estrogenic function, it causes thickening and viscid appearance of cervical mucus. And this does not allow ascent of sperm. Even when there is intercourse, it doesn't allow ascent of sperm into the upper genital tract, and it doesn't, by this, the sperm does not have contact with the egg. Progestin also has been shown to cause endometrial atrophy, and this makes the endometrium unreceptive to implantation. When women have used contraception, Nexplanon, for about 1 year, it has been identified that it is so effective that only about 0.05% of them will likely get pregnant. This statistics shows that Nexplanon or implants, they are so effective that they are more effective than sterilization, tubal sterilization in women. And as such, it is labeled for 3 years of use. Recent studies have shown that it actually can prevent pregnancy for about 5 years. But from the manufacturer's point of view, it is recommended for 3 years of use. It is important to reason because the implant is so effective because it doesn't require any effort by the user for it to be effective. When it is there, and it works independent of compliance of the user. However, in obese women or overweight women, available data has shown that even though the contraceptive concentration in the serum is reduced, this does not necessarily translate to reduction in contraceptive efficacy. But because of this, women that are overweight or they are obese, they are advised that there could be early replacements around towards the end of the third year of use. They can replace it early so that they might not have unwanted pregnancy. Contraceptive efficacy of etonogestrel is reduced by drugs that affect its metabolism, just like I said, anti-seizure drugs like carbamazepine, phenytoin sodium, antiviral drugs like efavirenz, and some tuberculosis drug like rifampicin have been shown to increase the failure rates of progestin-containing drugs. So, just like I said earlier, women that are using Nexplanon, they might advisedly be asked to use a backup contraception like a condom. Etonogestrel, however, still remain highly effective in these women and does not preclude use in them. I will be talking about the side effects of Nexplanon. Irregular bleeding is a common side effect of Nexplanon and is a frequent and the most common reason why women discontinue this method of use. Because the consistent level of progestin in the circulation as a method of contraception, it blocks the endogenous gonadotropins that is released from the pituitary. However, it causes abnormal follicular development, but does not reduce ovulation. In so doing, it's the estrogen that is produced, that is endogenously produced in the system, is still there, and there is normal development of the endometrial lining. But because there is consistent level of progestin in the system, there is no progestin withdrawal, and as such, there is no regular sloughing of this endometrium, such that the bleeding that comes from progestin is unpredictable because of prolonged period of non-sloughing off on the endometrium. And this becomes very dissatisfactory to some women. And they can complain about this as a reason why they want to discontinue the method. And this abnormal bleeding can come in different forms. It can come in with amenorrhea, in which the woman is not bleeding at all, or infrequent bleeding, in which the woman is having less than 2 bleeding in a period of 90 days. It can alter the interval of menstruation or duration of menstruation. It also can alter the volume of flow. Irregular bleeding often is not a reason to discontinue discontinue this method of contraception, and there are some things that could be done to mitigate the effect of irregular bleeding, so that the woman can continue this highly efficacious method of contraception. One of the things that can be done, I will mention them in order of preference. So the first thing that could be done is to use a combined oral contraceptive pill for these women. This can be taken for a period of 3 months. This has been shown to reduce the complaints of irregular bleeding and allow continuous use of Nexplanon. High-dose cyclical progestin can be used for up to 3 months, and this can be used for a period of 21 days, giving a 7-day break, and this allows for a scheduled bleeding, and this encourages women to use it because they can predict when the menses will come. If this is not applicable, then non-steroidal anti-inflammatory drugs can also be taken for a period of 5 to 10 days. If this is not available or this cannot be used, then tranexamic acid at a dose of 500 milligrams twice daily can be used for 5 days. If all these means of mitigation of the side effects of irregular bleeding does not suffice, then the woman might consider another method of contraception. Other side effects include headache, abdominal pain, acne. It can precipitate new onset of acne or worsen an ongoing acne. Weight gain has been discussed. For Nexplanon especially, studies have shown that Nexplanon on its own does not cause appreciable weight gain. But for Norplant has been shown to cause a weight gain of 1 kilogram for every year of use. So women can have some genuine reason for Norplant, but for Nexplanon and Implanon, it doesn't actually cause any appreciable weight gain. Breast tenderness is also a side effect. Dizziness, mood changes, and nausea has been reported in women taking Nexplanon. What are the non-contraceptive health benefits of women taking Nexplanon? Women that are having dysmenorrhea or ovulatory pain, Nexplanon has been shown to reduce significantly the incidence and intensity of dysmenorrhea in them, and also reduces or completely stop ovulatory pain in women that had it earlier. It has also been shown to reduce the risk of all pregnancies, including ectopic pregnancy. So if a woman is using Nexplanon, she is likely not to have ectopic pregnancy because she's not getting pregnant at all. It also reduces the risk of symptomatic pelvic inflammatory disease. And this can be linked directly to the fact that it causes a viscid cervical mucus plug, which prevents ascent of sperm. While it prevents ascent of sperm, it also helps prevent ascent of bacteria or infections that can ascend into the upper genital tract. Also, because contraceptive implants, they reduce the endometrial lining thickness. It reduces the amount of blood this woman loses every month, and also protect against iron deficiency anemia. Some reports have shown that it is beneficial in treating endometriosis, though it's not widely or is not a labeled drug for this indication. Contraceptive implants have been shown that they don't cause any clinically significant metabolic changes when they are used, especially because these implants are released continuously at low doses. And this is important and beneficial to women that have some metabolic conditions like diabetes, hypertension, cardiopulmonary disease, in which one might have concerns about a widespread effect of the contraception in them. It really doesn't cause any clinical significant metabolic disorder, because studies have been shown that check for liver function tests, renal function tests, coagulation profile, lipid profile. These tests have not been significantly altered by implants. What are the medical eligibility criteria for contraceptive use of implants? For all women that are being considered for implant use, especially Nexplanon, they must fulfill the basic criteria for use of hormonal contraception in the first place. So when this is done, then other things that might preclude use of implants in women include known or suspected pregnancy. For a woman that you are suspecting pregnancy, one should do a pregnancy test to rule out pregnancy before it is implanted. Any current or past history of thromboembolic disease. This is a contraindication that has been put in place by the manufacturer. However, the World Health Organization and the Center for Disease Control have indicated that progestin only contraceptive pill still represents a useful contraceptive choice for women with past history of thromboembolic disorder because of the things I mentioned earlier. It doesn't cause any significant clinical metabolic derangements. So it could also be used by them according to recommendation by the World Health Organization and the Center for Disease Control. Women that have hepatic tumor or active liver disease, they are not encouraged to use Nexplanon. Any undiagnosed abnormal genital bleeding is a contraindication because this might be an indication of early abnormality of pregnancy, like ectopic gestation, ongoing miscarriage. It could also be a pointer to a genital tract cancer, like cervical cancer. So this abnormal bleeding should be diagnosed before an implant is put in place. Any known or suspected breast cancer should also not be a candidate for contraceptive use. Any hypersensitivity to any component of this method should preclude its use in any form because woman can actually react to heat. Because of, just like I said earlier, for a woman that have diabetes, cardiovascular disease, and metabolic disorder, Nexplanon can still be used in them because it doesn't cause any worsening of their medical condition. And women that have HIV and they are on highly active antiretroviral therapy, they can still use contraception because even though we have a fear of reduced efficacy and increased failure rates, it doesn't preclude them from using an implant. They can still use implants and they can use condom because even most of these women still use condom to prevent sexually transmitted disease in them and prevent further new onset of HIV in them. So this contraception is actually not contracted in them. They can use it along with condom for better protection. Lactating women can use Nexplanon because it has been shown that it has no significant effect on milk quality or its quality. And infants that are being fed while their mothers are on Nexplanon, they have been shown to grow normally, even when they have been monitored to 2 years of use. Adolescents is an ideal contraception for adolescents because most of them, because of the high risk behavior and because of high level of unplanned and unwanted pregnancy in them, and because most of them use less reliable method of contraception like withdrawal method and condom, which they might not consistently and correctly use, they are at risk of infection. They are at risk of unwanted pregnancy, and they are at risk. We can push them to procure unsafe abortion, which can put them at risk of morbidity and mortality. So the American College of Obstetrics and Gynecologists, they recommend that implants is the first line of method for teens that are seeking contraception. Other health benefits include is the fact that it portends no further risk in women that have stroke or myocardial infarction. They can actually use contraception to prevent pregnancy in them. It has been shown when compared to injectable contraception, which has been shown to reduce the bone mineral density, Nexplanon does not actually show any significant evidence of adverse effects in the bone mineral density. So, for a woman that one is having questions about bone mineral density or risk of fracture, implant can actually be used in them. Even though breast cancer is a contraindication to it, recently available data has shown that the risk of implants on breast cancer is actually small. And for women that are actually using implant contraception, it has been shown that it reduces the endometrial plate thickness in these women, and so it's a pointer to the fact that it reduces their chance of having endometrial cancer, and also it reduces their chance of having, it doesn't increase their chance of having cervical pathology because there is no observable abnormal cervical changes in them. So, for any woman that we are considering contraception for, the important thing is to rule out pregnancy in them. And what can we do to rule out pregnancy in these women? One can rule out pregnancy by evaluating the menstrual history of this woman, the sexual intercourse history, and the contraceptive history of this woman. And this can be done if they fulfill any of the criteria I'm going to mention shortly. If the woman is 7 days or less after the last normal menses, and the emphasis here is the normal menses. So if a woman has a menstruation and the menses is not normal in terms of flow or duration, one needs to rule out pregnancy before she commences Nexplanon. The second is that the woman has not had sexual intercourse since her last normal menses. If she has had a sexual intercourse, then this woman needs to rule out pregnancy before she used Nexplanon. Then the woman has been correctly and consistently using an effective method of contraception. If the woman wants to switch to Nexplanon, she doesn't need to do a pregnancy test or use a backup. She can go ahead to use Nexplanon. Then if a woman is had a spontaneous abortion or induced abortion which is less than 7 days before commencing Nexplanon, this woman doesn't need to do a pregnancy test, doesn't need to use a backup contraception. Also, if a woman is not breastfeeding and she's still within 4 weeks postpartum, the woman can use Nexplanon without a backup or scare of pregnancy. But after 4 weeks, because it has been shown that after 28 days of postpartum, a woman can actually ovulate and she can get pregnant if she has sexual intercourse. However, for a fully breastfeeding or near fully breastfeeding woman, and she has been amenorrheic and less than 6 months postpartum, they can initiate Nexplanon without fear of conception. However, if any of these criteria I mentioned is not fulfilled, then abstinence is advised for at least 7 days after insertion, or a backup contraception is advised for 7 days after insertion. So I'm going to describe insertion of Nexplanon in the next few slides. For a woman that has been shown to be eligible and has chosen Nexplanon, those are the things that one will need to insert the contraception. Include a 25 gauge needle on a 2 or 5 ml syringe, a lidocaine, a 1% lidocaine without an epinephrine will be needed, an antiseptic solution to decontaminate the surface, an adhesive strip for closure of the strip, and it's also a sterile adhesive strip. Then an elastic pressure bandage is also needed. This reduces the risk of hematoma. A surgical glove because it's a sterile procedure, and a sterile drip to keep the field sterile. Then the sterile preloaded Nexplanon applicator. This is an office procedure, and is done under local anesthesia. For a woman that has chosen to have Nexplanon inserted, she's advised to lie on a couch and with her back, and with a non-dominant hand is flexed and externally rotated and placed under her head. The provider sits beside this patient, and this gives him or her a better view of the insertion, and she can at the same sitting trace the movement of the needle under the skin when it is being inserted. So this is the best position for the provider. One then identify the site of insertion, and this is identified using the landmark, and the landmark is the medial epicondyle of the less dominant hand. And the insertion site will be a position which is about 8 to 10 centimeters from the medial epicondyle. And this can be marked using a surgical marker, and the first mark is put at this 8 to 10 centimeters above the medial epicondyle toward the axilla, and the second mark is put about 5 centimeters proximal to this, and this second mark helps to show the direction of guide of insertion of the Nexplanon. One avoids to directly insert through this marker, because this can cause tattooing of that part. It can cause a permanent tattoo from the marker. Then one cleans the insertion area with the antiseptic solution, and about 1 to 3 mils of 1% lidocaine is injected under the skin along the intended site of insertion. The Nexplanon applicator is grasped above the needle cap at the textured surface between the thumb and the forefinger, and one carefully remove the plastic needle cover of the of the applicator. And when one does this, because the rod is inside the needle, one tries to raise up the needle so that the implant does not fall off, and at the same time one can view the implant that is actually in the applicator. Then one place the needle against the insertion site at about 30 degrees to the skin. It is shown on the slide, and while applying counter traction on the skin, the needle is inserted until the bevel is just under the skin. When the bevel is under the skin, then the applicator is lowered such that it is parallel to the skin, and is advanced until its full length is inside, while gently lifting up the skin with the tip of the needle. This maneuver ensures continuous placement of the needle under the skin and not in the subcutaneous tissue, such that when the implant is deposited in the skin, it is easily palpable. After this, the purple slider is put slightly down, and after that, it is fully drawn fully back. This deposits the implant under the skin, and the applicator can be removed after this. The implant placement is verified by the provider by palpating the two ends of the implants immediately. The woman is also asked to palpate to confirm placement. Then the small adhesive band is applied on the insertion site to keep the style sterile. And then a pressure bandage is put in place to prevent hematoma. After this, the patient chart label is completed for a medical record, which will be kept at the family planning clinic, and the user's card is also completed, which is given to her. This user's card gives the information of when to come back for a replacement, which will be after 3 years. The pressure bandage can be removed after 24 hours, after which the risk of hematoma is unlikely, and the adhesive strip is removed between 3rd and 5th day. Most women don't have problems with pain, especially when the implant is correctly implanted. However, some women might need analgesia because of complaint of pain. And pain relief such as ibuprofen or paracetamol can be given to these women. However, if this woman pain is persistent, then she might need review and she might need to come to the hospital. The patient is discharged immediately after this, and she really doesn't need a follow-up. The complications of Nexplanon is closely linked to its insertion and the technique and the skill of the person providing this contraception. And the complication reported has been between 0 to 1% during insertion and 0.2 to 1.7% during removal. Infection at the site is one of the common complications, and it occurs within the first 2 months, and this can be linked to poor aseptic technique during insertion. Hematoma formation has also been reported, and this might actually also be due to not being able to avoid the blood vessels along the path of the implants. Nerve injury has also been reported, can cause neuropathy, and the woman, this usually is a reason for removal of the implant and replacement in a better position. Expulsion of the implant has also been reported, and this can occur within the first 6 months of insertion. Difficult removal has also been reported. However, this is actually significant in non-plants, and is one of the reasons why women could not continue its use, because some women have difficulty enduring the process of removal of Nexplanon because of the fibrosis it has caused. And this is now a contraceptive. This is now an advantage in Nexplanon because the plastic containing the active ingredient causes less tissue fibrosis, and so the fibrosis in them is unlikely. During removal, implant breakage has also been reported. So when implant is removed, one should actually check properly if the whole extent of the implant is intact. If there is any leftover part, then the woman might need further review. Improper placement of implants in other parts of the body like blood vessels has also been important, and this also boils down to technique of the service provider. For removal of the contraception, after 3 years of use or any other indication of removal, the woman is also brought in. It's also a office procedure, and it is done under local anesthesia. The equipment for the removal is same as listed for insertion, except that the applicator has been replaced with a scalpel and a sterile mosquito forceps. The position of the patient and preparation of site with antiseptic solution is as done during insertion. And one locates the implants by pushing the proximal end down, and this push out makes the distal armpit bulge towards the elbow of this woman, and this can be shown in the slide that is adjoining. After this, one injects about 0.5 to 1 ml of lidocaine under the implants where the insertion will be made. And it is important to inject this under the implant, because if it's injected over it, it's going to blur the sites of incision, making removal more difficult and identification of the implant more difficult. After anesthesia, then one starts with incision of a 2 millimeter longitudinal incision on the tip of the implant, and the incision is made towards the elbow. When this is done, the implant is pushed towards this incision, and the implant usually pops out from the incision sites. After this, the implant is grabbed using the sterile mosquito forceps, and it is removed by pulling towards the elbow. The incision site is closed with the adhesive stripe, and bandage is applied. The adhesive stripe is removed after 3 to 4 days. However, the bandage is removed after 24 hours of use. I will briefly speak about the Jadel contraception. It is also an implant contraception. It contains 2 rods containing levonorgestrel implants. Each rod contains 75 milligrams of levonorgestrel, and the total of which gives a total of 150 milligrams of levonorgestrel. The Jadel rod is wrapped in a stylistic plastic tubing measuring 43 millimeters in length and 2.5 millimeters in diameter. Jadel is labeled for 5 years of use, and during insertion, it is inserted such that the 2 rods are inserted in a V shape with opening towards the shoulder. Nexplanon is the discontinued implant I spoke about earlier. It contains 6 rods, each containing levonorgestrel implants, and each capsule contains 38 milligrams of levonorgestrel. The capsule is about 2.4 millimeters in diameter and 34 millimeters in length. It releases about 60 micrograms of levonorgestrel daily, and in the first 500 days of insertion, and this plateaus at 30 micrograms per day over the remaining 7 years of use. The annual pregnancy rate for Nexplanon use has been quoted to be 3 per 1,000 users, and the mechanism of action is primarily by cervical mucus thickening and ovulation inhibition. So, in summary, during this session, we've been able to describe what contraceptive implants are, that they are progestin-based, long-acting reversible contraceptive implanted subdermally, and they are highly efficacious and effective, ranging between 3 years for Nexplanon and Implanon, and 7 years as seen in Norplants. The mode of action include ovulation inhibition and thickening of the cervical mucus plug. It is safe, it is cost-effective in most women. The most common reason why women discontinue its use is because of the commonest side effect, which is irregular bleeding, which can be treated with some medical treatment. Thank you for listening.